I'm presenting on behalf of the co-authors that are listed. So effective interprofessional practice, which I'm going to refer to as IPP, improves the quality of patient care. And interprofessional education and practice are not emphasized in the pre-service curriculum of many health professionals' training. And yet we know that a collaborative workforce committed to interprofessional practice will greatly contribute to transformation of the health care system in Uganda. Whereas this IPE is currently employed at Makerere College of Health Sciences, little is known about the students and the faculty perceptions and attitude, as well as their needs and challenges in implementing it. And we also know that there's been increased attention to the ethics and professionalism of healthcare professionals from healthcare providers, patients, the community, the media, and the general public in Uganda. There's been reports of unethical and unprofessional practice in the healthcare that have been increasingly correctly and sometimes incorrectly reported, with cases such as absenteeism from work, negligence, extortion of money from patients in critical condition in the public facilities, to mention but a few. And unethical and unprofessional conduct by healthcare practitioners substantially affects the healthcare system, with effects such as increased patient negligence, increased morbidity and mortality, and lack of trust from the public. Therefore, strengthening interprofessional education for collaborative patient-centered practice may contribute towards solving this escalating problem. So the objective of this situation analysis was really to find the need to do a needs assessment of interprofessional education and practice among faculty and students to be able to guide the development of a relevant and effective interprofessional training curriculum for ethics and professionalism at Makerere. We conducted the survey at Makerere and Mulago National Referral Hospital, which is the teaching hospital for Uganda, and study participants were mainly students from the medical school, Makerere College of Health Sciences, and faculty from the various programs. And we performed a cross-sectional study design with both qualitative and quantitative methods, including focus group discussions, in-depth interviews, pre-tested questionnaires, and direct observation of tutorials and ward rounds. So the results, we found that interprofessional education is very well articulated in the MDCHB program objectives, competences, and design, as well as structure of the curriculum. However, the means of delivery do not clearly describe how it is to be operationalized and achieved. The first course in the curriculum offered to the students is Foundations of Health Professionals Education, which introduces them to professionalism and ethics. And the course on medical ethics, human rights, and professionalism covers the subject matter at a higher level. However, it's not clear how competence in professionalism and ethics is assessed. When we came to the focus group discussions and interviews, we found that nearly all participants could define what interprofessional education and practice is. They knew what it was. They understood the concepts. And they reported interprofessional education as being very well articulated in their curriculum, training curriculum. And they were knowledgeable about the benefits. And some of the benefits mentioned included effective service delivery, better health outcomes, holistic care to patients, making the work easy, saving time, solving understaffing problems, improving student and staff relationships, creating teamwork, and promoting ethical practice between and within professions. However, they all noted variations in the way interprofessional education and practice is being implemented at the college as well as Mulago Hospital, as I'm going to show. Whereas some respondents responded interprofessionalism as being well articulated in the curriculum, more than half of them said interprofessional education is only taught or conducted in the preclinical years. And there were several gaps identified in the implementation of both IPE and IPP, such as concepts not being very well programmed, limited number of skilled healthcare workers to implement IPP, and health workers lacking motivation, poor communication between the faculty and the students. There were mixed views as to whether interprofessional practice is actually being practiced in the training facilities, with less than a quarter of the respondents reporting that it was implemented in their teaching health facilities. So only less than a quarter reported the existence of IPP. Most participants reported not having seen IPP being implemented in their training at all. And I'm going to cite some of the quotations from the respondents. At the moment, it is well established, although it has its own challenges in terms of numbers, the content of information being given to the students, being able to balance the content to suit the different professionals is a challenge to the lecturers as well as the students. The classes are usually big, and it becomes a problem keeping them together to see that they have actually learned something just because of the numbers. This was somebody from the Department of Surgery. Each group has different needs and learning objectives, so it is hard to harmonize and conduct a singular group session. Timing is a problem because the curricula are conducted at different times for different disciplines, hence mismatches. Assessment should also be integrated to demonstrate the relevance of the various disciplines in patient care. What we train as the ideal in IPE, interprofessional education, is not what the learners find out there in practice because of inequalities or poor distribution of professionals. The distribution is controlled by other factors which are beyond our control. That was somebody from the family medicine. And from the students, one of them said, for us as dental surgery students, we have not started learning anything about dentistry. So we all learn irrelevant and unnecessary things like the anatomy of the leg and embryology as a course unit. Then another one said, some of the activities seem out of your profession. At the moment, for example, BDS students are rotating in pediatric and maternity wards. So they didn't seem to see the relevance of IPE. Then the key informants, all of them responded and told us, we could assess from their responses that they were knowledgeable of the concepts of interprofessional education and practice. And they all noted that IPE was well established, but with challenges. And some of the challenges noted included lack of coordination, large number of students, limited staff, and lack of faculty commitment to the IPE concept, among others. This is somebody from the Department of Obstetrics and Gynecology who said, I think there is lack of respect for each other's professions, where if all would consult each other, it would benefit the patient. The college has done its part, but the practitioner's mindset is totally different. Their first priority is survival. This is a very dangerous phenomenon. In the end, it hurts the patient. Some of the factors identified as affecting the implementation of IPE and IPP included poor attitude of faculty members, limited government support for health workers, patient ignorance of their rights and where to report to when their rights are violated, economic factors such as little pay for the healthcare workers, disrespect and lack of appreciation of the health workers, lack of knowledge, limited human resource, and inferiority complex among some health professionals. And these are some of the quotes from the respondents. Unprofessionalism is a big problem, considering that health personnel are not paid their worth, so they resort to other means of survival. That is a student, you can imagine. Ethics is taught at the beginning of the program, and for some programs there is little teaching at the end. This should be continuous. Unprofessionalism is due to limited resources, even within departments, poor culture and hostility of the general public, and the rampant poverty that is prevailing lures professionals into corrupt business to earn a living. The participants also provided some solutions to solving this escalating problem, and some of these included formation of professionalism clubs, reviewing the current curriculum, increasing funding, increasing availability of mentors, reducing the numbers trained per session, having more staff recruited and trained on the IPE model to help reduce the workload, and the curriculum to be trained jointly, staffs to be trained in the IPE concepts, have model IPE sessions for students, structure training goals to address the student needs, provide refresher training on the importance of IPE, and improve mentorship. The others, these are some of their own quotes. Split us into manageable numbers. That is a third-year student from MBCHB program. I believe that the curriculum should be tailored together with lectures from the different departments so that input is substantial. We need to form professional clubs supported by our lecturers. Lastly, I would like to acknowledge Professor Nelson Sewankambo, who enabled us to perform this survey, the investigators, some of whom are in the room, the participants, and research assistants. Thank you very much.
Thank you so much, Pauline.